just to present myself. So I'm a neonatologist, okay? And I work in France at the northern extreme of France. I'm from Lille. I work in a level 3 unit, and I'm also an epidemiologist. I have been implicated in EPIPAGE 1 and EPIPAGE 2. I don't know if you heard of those studies. And I'm actually in EPIS also. But I have some limits. And so the first thing, I'm not a statistician. So we're going to speak of what I found a bit complicated concepts, but it's not a statistical point of view. It's rather what I would like to do is give you insights to understand how it works and how you could use it. My second limit is that I'm French, so my English is not perfect. So please feel free to tell me if a word is not understandable, because maybe it's a French-English word, okay? Really, don't hesitate. So that's for my part. And I'd like you to present yourselves so as I know, as we know, who we're dealing with. Because the problem is I don't know your levels. And so some concepts will be very basic for some of you, and some will be maybe a bit complicated. So you really have to stop me when it's out of your frame or not. Yeah. Yeah. Yeah, that's perfect.
During the coffee break, we will place it inside. You're welcome.
Okay, so yeah. Oh. Success out for the internet. Okay, so we're on the internet, so be careful what you're saying, who you are. Okay, so yeah.
Hello, my name is Suvi Turkka. I'm an MD and doing my PhD about preterm birth, and it's a register study, and it's an epidemiologic study too.
Okay, so you're doing a PhD in epidemiology about preterm, and you're a medical doctor in what field?
Just
Yeah, pulmonology?
no, it's general, yeah. Yes, yeah, someday.
What country?
Finland.
My name is Petteri Hovi. H-O-V is Vanessa I. Hovi. I am a medical doctor and a PhD. Got my PhD done 2 years ago, and it was about the clinical follow-up study of preterm babies until adulthood. And now I'm flipping to register studies, and my limits are that I'm not I'm Finnish and not a statistician, so we are in common that way. Yes.
My name is Katrine Bach. Yes. I'm a medical doctor and a PhD student at Aarhus University Hospital in Denmark, in connection to the pediatric department. And I'm doing a PhD also in epidemiology concerning environmental toxicants and early development. Yes.
My name is Gabriele Luft. I'm a yes. My last name L-U-F-T. I'm a nutritionist with a PhD in clinical nutrition and working for a pharmaceutical company. And we do have pediatric products for pediatric patients, so I'm supporting our products in the medical department. And my limits are, yeah, the knowledge in clinical trials and so on, so therefore I'm here. Not very good, yeah.
Good morning, everybody. My name is Goran Venčina. I'm from Croatia. Croatia, yes. I'm a clinical pharmacist. but I have a PhD in epidemiology, and I work for a pharmaceutical company as a public health manager for pediatric vaccines.
My name is Marina Cuttini. I am a former neonatologist. Now I work as epidemiologist in a pediatric hospital in Rome, Italy.
My name is Ileana Croci. I'm Italian and I'm a student in statistics. And statistics. And I work with Marina.
Okay. Okay, thank you very much. So one of my questions would also be, what are you waiting from this session? Let's do it like that. Who wants to say if you had an idea? What were you expecting coming in this group? Because you have real different origins. And nevertheless, you chose this group with an important program, so maybe some topics are more relevant for some of you, I don't know. Or some of you have used some of those topics. Did some of you use propensity score ever? No. DAGS? Yes, you use DAGS. Oh, so you're going to help us, I hope. Okay. You use DAGS in what field?
I haven't, I've tried to use it in my own project to try to find out what to control for, but I'm not sure that I'm going to use it when I write my papers. But just to find out how everything is connected. And,
That's interesting because we're going to, we will be able to discuss on what you tried to do, because I feel it's quite tricky also. So it's not straightforward, the use of DAGs. Okay. And meta-analysis, have you been implied in meta-analysis? Yes, you also. Okay. And randomized trials or rather epidemiologic studies in their meta-analysis? Randomized trials. Ah. Okay. Okay. So this afternoon, maybe you'll have insights on the important points of epidemiologic meta-analysis. Okay. 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 And we saw that there was already. Oh, yeah. And you rather worked on hospital-based or population-based data?
To the question, we have population-based data now, but I want to say one thing that I wait, because I saw in the titles already many things that I haven't been using, so I'm very happy to hear about them, and my near future job will be to combine data from clinical epidemiological studies, from multiple studies, and it's kind of a individual data meta-analysis kind of thing. So in that background, I'm really looking forward to hear new ideas.
Okay. Okay. Fine. Yeah. Okay. Were there other specific points you were waiting for in the workshop? No, as a pharmacy, because we have two pharmaceutical company. The field, in that field, which is a bit peculiar. What are you waiting of? What are you going to try to apply? Have you got an idea already, or it's just curiosity, which is good, which is good. Yeah, curiosity. Yeah, you too. Okay, okay, okay. So let's start by the collider problem, and honestly, it's it is a bit difficult problem, and I'm going to try to lead you up there. So what would you say is confounding? She should know. Would you know? Yeah, don't be afraid. Honestly, we're just discussing. You'll just be on the internet, that's all. No? It's too difficult? How would you define a confounder? Yeah.
I think this is kind of dangerous in the internet and not everything. Don't listen to me, anybody. Okay, but confounding is, in my point of view, that we have a relationship between, let's say, thing A and thing B, and we are studying the relationship, and then there is a C that might be a confounder, and it means that in fact there is no true relationship between A and B, but the C is related to both of them and is causing so that we see relationship in the absence of it.
Yeah. That's quite right. Yeah. I don't know if I would say that there is no relationship between A and B. It's just maybe that the relationship we see between A and B is a bit false or very false. We have to explore that because it's distorted by the confounder. But sometimes nevertheless, there is a relation between A and B, but I'm going to come over that. So, we're going to see also how to deal with confounders, and we're going to talk about adjustment. But there are other types of variables which are colliders, and how to deal with them. So, the confounder. So I'm taking an example between smoking, thank you, and forced expiratory volume. So the idea is that when you smoke, you could reduce the forced expiratory volume. I'm glad to give you my presentations if you email me, and I'll give my email at the end. So rather try to understand than try to copy everything, because it's going to be a bit heavy to copy, I think. And the question we can ask ourselves is, what's the influence of age on this association? And that's the first point. I'm not talking of causality, I'm talking of association. Yes, so that's a very important point on which we're always going to come back. You have to distinguish association and causal association, which is another problem. So, the more your age is important, the more you smoke. So age is associated with smoking. And the more your age is important, and the less your first expiratory volume is. So there is also an association between both. And so the problem is the association I'm observing between smoking and FeV, is it real, or is it induced by age? And what do I mean by induced by age? That would mean that, for instance, smoking, you are a smoker or not smoker, and it would mean that in the smoking there are more aged people than in the non-smoker. And like the aged people have a reduced FeV, the fact of having more aged people in the smoking group will induce the relationship of reduced FeV. So that's my problem. So one of the ways of getting rid of the effect of age could be adjustment. What do we hear by that? Well, let's take what we're going to look is in smokers who are old, more than 53 years. Is FeV reduced? Well, yes. Yes, in aged persons, FeV is reduced. And in young persons, is FeV reduced? Yes, also. So that means that being old or age, smoking still reduces fever. So there is a proper effect of smoking, okay? And that's what the tests do. They calculate some estimates at each strata of your confounder, and if it seems reasonable, they compact it in a global estimator. So, there is an effect, a proper effect of smoking on fever, independently of age. And yeah, that's why I suppose you're young or old. Let's take that one. Twins have increased mortality. What would you think of prematurity? Would you think it's a confounder? Because twins are more often premature. And prematurity increases neonatal mortality. So once again, I'm asking myself, is the association I have in the crude association between twins and mortality, is it only the effect of prematurity? Well, the problem is, and must I adjust on that? Yeah. Absolutely, absolutely, and this is the importance of the direction of the arrows. In the age and smoking, it's age that induces more smoking. As in twins, it's rather the fact of being a twin that is going to induce prematurity. So the direction of the association is also important in the definition of a confounder. And so prematurity could be considered rather as an intermediate variable between twin and mortality. Okay? So it's not quite the same thing. So I showed you an adjustment on one variable, which was age. And there are mathematical models that can permit you to adjust on several variables. And you have an explained variable, which is fever. You have an independent, which is finally what you are studying. You are studying the relationship between smoking and fever. And you try to get rid of some effects that are confusing your association. And this is very important when you are analyzing data. It's to take a time to ask yourself what question you're exploring and not put all the variables in a model and just see what's coming out, okay? So never mind the type of regression. I think that is a biostatistic problem, and so we need a biostatistician who will take the good type of regression. But when you see in a paper that there's multivariate analysis or multivariate regression analysis, that is, we are trying to adjust on confounders. So, what do we hear by association? When we say that there's an association between gender or sex and birth weight, that means that if I know that Smith is a boy, then I can suppose his birth weight will be smaller or higher, okay? And in that case, it's rather that girls have smaller birth weights. So having an association means that if I know in what category the patient is, I can suppose that the result on what I'm exploring will be higher or lower. But it is not causality. Once again, there is a very high association in having a lighter in your pocket and having a pulmonary cancer. It's very statistically significant, okay? Well, why would you say it's not a causal association? Are you okay to say it's not a causal association? No? Yeah.
I think this example, it kind of is a cause, because although there's an intermediating factor, the cigarette in between, the ultimate cause of what's happening is the lighter.
Yes, but so why would you be more enhanced to think that cigarettes would rather be causal and not lighter?
Okay, you win. So the cigarette is the thing that is needed there. That is the matches will do, yeah. And the lighter is not needed. But in this case.
So why doesn't it work between lighter and cancer? Well, when you look at an association, in the arguments for causality, there is the mechanism, and intuitively. You knew that a lighter could not give a cancer. And that is because one of the very important points for causality is that there are no mechanisms between the lighter and the cancer, okay? So it's an indirect indicator of something, but when you're thinking of causality, you have to look for a physiopathologic hypothesis, okay? So, here is what they observed, and they calculated the forced expiratory volume. And as you can see in smoker, the mean FEV is lower than in former smokers. So, how can we try to find those confounders? Well, there is a tool who has been proposed. It's the DAGS. Which is the name for direct acyclic graphs, or you can use it as a diagnostic graph. And the use of those graphics is to try to put on a paper all the mechanisms of associations and factors that are implicated in your research topic. And so you have an association between A and B, but it can come from multiple other factors intervening in the paths of A and B. And so, saying that you have an association between A and B, you have three possibilities. It's A that causes C that causes B. That was twin prematurity and mortality. It can be A causes C and B causes C, which we're going to come upon later on. And it can be an association, but in the other way around. That is, B produces C that produces A. So, that's the same thing, but just with a diagram, okay? And as you see, I said there are 4 association mechanisms, and I only give you 3 for the moment, because we'll talk of the 4th later on. So, as you said, when you have a confounder, that is C causes A and C causes B, it can induce an association between A and B. Or it can induce a part of this association, okay? So body weight increases cholesterol, body weight increases blood pressure, and if you looked at the association between cholesterol and blood pressure, it could be positive, okay? And so again, saying there's an association is to say that knowing a bit of C, I can guess A, and as knowing a bit of C, I can guess B, that is, knowing A, I can guess a bit of B. It's like that it works. Okay, so you should ask yourself, there's an association, and what's the direction of that association? And for instance, bronchitis, which is also a mechanism that reduces pulmonary function, is it bronchitis that gets fever reduction or the other side along? Well, you have to think of chronology. It's first bronchitis, and then there was a reduction of fever. And that's another causal argument. You have temporality. It's very important because for instance, in some case control studies where you ask if they were transfused, for instance, and you look at do they have hepatitis, and you don't know if they were transferred before or after. So you can't have temporality, okay? And that can be a problem. That can be a problem. So what is the idea between adjustment? It's to block the path one way or the other. And we do that, we can do that by 4 ways: randomization, matching, stratifying, or adjusting with regression. So, randomization, you have to think of randomization. A is the treatment, in fact, so treatment or placebo, okay? B is the disease. And if I randomize the treatment, treatment and placebo groups will become comparable concerning the confounder I was thinking of here. So, if I say that treatment and placebo are comparable for gestational age, that means that I cannot guess treatment or placebo knowing gestational age because they're the same in both groups. So what I have done is that I have suppressed this association. So randomization is a very powerful way of getting rid of an association. The second way is matching. Matching is simple, is that for every, so there was, for instance, we could look at patients taking Mediator. That was a big affair in France, which is a treatment for diabetes, and taking it or not, and I could see if it gives unexplained aortic valve disease. But unfortunately, one of the indications of Mediator is also obesity. And obesity gives unexplained aortic valvular diseases. So, what I can do is for every patient taking Mediator, I take a control with the same obesity status, okay? So that's at the moment of the protocol. For each inclusion, I take a control with the same characteristic of the confounder. So of course, that will induce comparability of exposed and non-exposed concerning obesity. So once again, I have blocked the path. Is it clear? Tell me if it's not, yeah. Okay, conditioning. So conditioning or adjusting or whatsoever. What you do is that you look at the association between A and B at every strata of the confounder. That's what we made with the first example. And so you look at, in males, is there an association between A and B? And when you do that, you block both paths, because, of course, in A there are only males, and in B there are only males. So there can't be, you can't guess the association between A and B knowing C, because C is the same in both groups. So you block both paths. And this is what adjustment can do with the calculation of a global estimator. I'm going to show you some examples. Okay, so this is conditioning. For instance, if we had considered prematurity as a confounder, which is maybe not a good idea, well, we should have looked at in-term twins, is neonatal mortality increased? Yes, it is. In preterm, yes, it is also. You have separate estimates, and you could calculate a global estimate, which would give you the effect of twins on mortality, getting rid of gestational age effects. Okay, watch out, because you could also see an association in both strata, but who go in different ways. And there it is not reasonable to calculate a global estimator. This could be stated as interaction, and so there are other ways of dealing with interaction. But you have to look at the estimators by strata, and maybe we'll see that on the hands-on journal. Okay, so this was for confounder. Do you have any questions? No, not for the moment. Don't be shy, huh? Okay, so let's go to colliders. The definition of a collider is that it's a variable which has two causes. So as you see, the arrows are both going on the collider. So how does this go? Well, if you condition on the collider, you look, so we're looking at, brake condition, street condition, and did it lead to an accident? Okay. So you could say that let's look at, if we adjust on, let's look at every strata of accident, okay? So you look at those who had an accident. If he has bad brake condition, you can't guess the street condition. It could be good, or it could be bad, and he would still have, okay, he would still have had an accident. But if he has a good brake condition, he has to have a bad street condition. There are, of course, some hypotheses, strong hypotheses behind that, is that there are no other factor intervening. I'm simplifying, okay? So if you can associate information, that means that there is an association. That was the definition of the association, is that knowing one status, you could guess the other one, okay? Looking at those who don't have any accidents, if you know that the brake condition was good, you can also say that the street condition was good. And that's why he didn't have any accidents. So what we see there is that there is partial guessing, between brake, street, and accidents, and it is induced by the conditioning on accidents. As at the origin, there is no real association. So what we're going to see is that adjusting on a collider induces some new paths. I'm going to show you some more examples. So the four association mechanisms, the fourth is conditioning on the collider. And that's a problem, because you're going to induce false associations. So, confounder induces a path of association, and you can try to get rid of it by conditioning or adjustment, okay? As collider blocks a path, and if you adjust on it, you're going to induce false associations. So it's a problem to adjust on colliders. Alors, saying that you're looking at smoking, sex, and respiratory function. Try to write on your paper the DAG you would do for these three variables. How do you imagine the association between smoking, sex, and respiratory function? So try to put the three variables and put the arrows where are the arrows going? Okay, you have an idea of the arrows, yeah? Yep. Yeah, is everyone done so, already do you find it a bit difficult to put the arrows or not? No, it was simple. Luft, did you find it simple, straightforward, or? Yeah, a bit. Yeah, okay. So, I find it not always so simple, huh? So here, I would say that you have smoking and you look at respiratory function, and males increase smoking, and males have reduced respiratory function. So this could induce the relationship between smoking and respiratory function if, for instance, there were more males in the smoking group. Yes? Okay. Wait.
Can you also say that the arrow may go the other way is if people who have problems with
here?
change as
So, yes, it could. Yes, that's a vicious remark, but an interesting one. That's true. You can have A who is association, who causes B, who causes A. Yes? Effectively, those who have a restricted respiratory function could begin to reduce smoking. That's true. But actually, it's not A that induces B that induces A. It's A1 that induces B that induces A2, because it's not the same A. It's A after having had a reduction of respiratory function. So it's not a double arrow. The A we're talking about are not the same. Is it clear? Yeah. So that's very important as a question, because it's true that sometimes you say, yeah, hey, wait a minute. It's true that restriction, but it's not the same patient. He has already restricted respiratory function, and so it's on another variable. So temporality is really important in terms of thinking of the arrows also. So that's what we can do calculating, okay? You have a reduction, that's what we saw in the first results. Respiratory function is reduced in smokers. And what you can do is look at in men and in women. That's adjustment, okay? That's conditioning. And you see that you have, yes, a bit reduced in men and a bit reduced in women. And, well, the software or the test or the statistician calculates a mean difference. And you see that that was the crude effect, but in that you had the sex effect. And when you adjust on it, you find another association with the sex effect, taken apart of the sex effect. Okay? Or is it puzzling because, no? Okay. So this is the same thing, but for bronchiolitis. And why do I give you this example? It's because you can also do the same thing with odds ratios, okay? Before it was a mean difference, and now it's an odds ratio. And you also see a modified odds ratio after adjustment. This is a really important point, is that when you see your effect, and after adjustment you see a modified effect, it is in favor of there was a confounding effect. If your indicators don't move so much between adjusted and non-adjusted, well, the effect is probably not important or not existing. Okay? So just looking at results between crude and adjusted, if you see many changements, is that there are associations that are giving you a false impression in crude indicators. Okay? Okay. Hi, Luigi. So, now it's a bit more complicated about confounders. Because we can look at more than one confounder, as I said, talking about regression. So try to draw your diagnostic graph. So we're still looking at smoking and respiratory function. And how would you look at age and sex? Yeah, we began with a bit, we were a bit, no, it was a, yeah. You see, they put 9 o'clock here, and they put 8. Yeah, no, but that's what they were saying, that's a, Okay. Okay, have you got an idea of the DAG? Sobitur, that's it. Your name? Your name is? Your name? Sovi. S-O. Suvi. Okay. Okay. Are you all right with about the DAG? Maybe. Yeah. Okay. So here it is. So you see, it's beginning more complicated. Just don't look at asthma. Wait, excuse me. We can also put in it asthma and physical activity. So you see it's going to become a bit more complicated. Where do you put asthma? So what you have to do is put asthma on your graph and try to put arrows between asthma and the rest. Okay. And the same for physical activity. No. Yeah, I see hesitation, huh? It is difficult. It is difficult. So this could be a proposition. You see, first of all, let's just look at age, sex, smoking, and respiratory function. So age is linked to smoking, yes? And age is also linked to respiratory function. And it's the same for sex. So you would have a double triangle. Just don't look at smoking. Don't look at that. Don't look at that. Don't look at that. Just age, sex, and both. Okay. So in fact it's a double triangle. Okay. And then after that, when you look at, never mind this one, at physical activity, well, age is linked to physical activity. That's clear. And physical activity is linked to respiratory function. Asthma, well, maybe you don't know, but asthma is linked to sex, and asthma is linked, of course, to smoking, and asthma, in fact, is also linked to respiratory function. So you could draw an arrow. So you see, it's a bit complicated, but I think it's really important to take time to try to find where are the arrows and in which direction they go. It's a part of analysis, but I think it's also a part of planning a study. Because when you plan a study, you have to think of the variables you will collect. And so it's important, well, you can use the tool to try to see which variable you will need, knowing what you have read in the literature. Absolutely, absolutely. So that's the problem of epidemiology. After a while, yeah. The problem in epidemiology, the two groups we compare are never comparable. That's it. So we have to try to take out confounders. And one of the major problems is that we don't know all confounders. And I would say that on the other way around, randomization, the extreme force of randomization is that it leads to your two treatment groups comparable on all confounders, but known and unknown. What we hope is that chance will, put both groups strictly comparable on confounders, but also on unknown confounders. There's only randomization that can do that. This is why the level of well, it will come back in English, but this is why we are more likely to believe in the result of a randomized trial than an epidemiologic study. It's because we can't manage every confounders, and especially the unknown. The unknown or the non-collected. Yeah. So this is why you have to plan a bit for your variable collection, because really, if you do a core study, you have 2 years follow-up, and then you realize that you're missing tobacco. That's a drama. Yeah. Yes, you wanted to say something.
I think DAGs are very good for getting an overview and get like the main picture, but they're always sort of too simple. For example, in your DAG, I would also like an arrow from sex to physical activity, and I think there should be a direct arrow from age to FEV, and it's always... That's true. It simplifies, but we're going to come on the arrow between sex and physical activity afterwards. So that's the first step of the DAG, and effectively there's missing the arrow. And effectively, age could have a proper effect on respiratory function. Yeah. So, but you see, saying that is that because you have looked over the arrows, and so yes, I would put that arrow. That means that I have to adjust not on physical activity, but rather on age. Yeah, because there's a direct arrow. Yeah. Okay. So DAG is not the solution. DAG is really, I think we underuse DAGs. And using DAGs pushes us to try to understand what are the associations, and therefore look at temporality, pathophysiological relationships, and so I found it better than not doing it, but it doesn't resolve all the problem. I totally agree. So what should we do? Well, we could adjust on confounders. We could also stratify, as we did looking at men and women. Okay, so we can look at asthmatic, non-asthmatic, and in the asthmatic, look at physical activity. So we're going to stratify on every variable. Well, the problem is, if you have 200 patients and you split them in all the stratifications, well, you're going to have very, very little power
to look at the associations. So a problem with stratifying analysis is that if you put too many variables on the stratification, you're going to lose a lot of power. And so everything will get out non-significant. So you have to choose which variables you want to adjust on, and rather with the idea of being parsimonious, you know, the less the better. So what do we want to do by adjusting? It's to block the paths. So we could adjust on age or sex, which are confounders. And you take into account all the other effects. Actually, to block a path, you have to adjust either on the initial variable, either on an intermediate variable. You could. We could, for example, adjust on asthma and physical activity, if the DAG is like that, okay? Because if I adjust on asthma, I block the path between sex and smoking and fever. So it depends on the variables you have. It depends if you have planned the study or not, or if you have a set of data, and, well, it's not very probable, but let's say you have a lot of missing data in age, but you have good data on physical activity. Well, you could adjust on physical activity, which would block this path. So, if age is a confounder, you have to have this path and this path. If you block this path, it's no longer a confounder. Except that, in fact, age has a direct effect on FEV. So there's an arrow missing here. And so adjusting on physical activity will not be sufficient to block the path for age, okay? Yeah. But the problem is, as you said, there is also a relationship between sex and physical activity, if I may say so. And that's a collider. Physical activity in your graph becomes a collider because you have two causes linked to physical activity. And so you should not adjust on physical activity. So, because if you adjust, you will induce a new path. Actually, when you adjust on a collider, you open a path between its two causes. Okay? So it's another path to block. Yeah. Yes, or is it? Are you still on your bicycle? Yeah. So we could propose, for instance, to adjust on age, sex, and asthma. Because actually asthma is linked also to respiratory function. There's another arrow that appeared here. Okay? So DAG helps to think about which variable I could adjust on and which I shouldn't. But I don't know all the variables, and sometimes I miss some arrows. Yes, I agree. But if you don't do DAGs, how do you choose your variables? What was the other method for choosing your variables? So you had a list of variables. You looked what was associated to both the exposure and the disease, and you said it's a confounder. I suppose that's how you choose a confounder, an adjustment, no? Well, we're going to come on that on the hands-on session, but generally what you do is you do a table exposure, yes, no, and all your variables, and you see those who are significantly associated to the exposure. Then you do another table, disease, yes, no, and you look at the associations between all your variables. And those who are associated in both tables could be confounders because they are associated to the exposition and to the disease, which is the definition of confounder. But be careful because it's not only association. The arrow has to be in the right way. Yes?
I think that the third common way of doing it is making a list a priori based on mechanisms and then just taking all of them. The ones you would put in your DAG probably and just adjusting for all of them.
Yeah. Yeah. So you have to think of mechanisms, and that helps to put your DAG. Because when you're thinking of mechanisms, it's the beginning of the design of the DAG. But the aim was to just give you an insight on DAGs, and I hope that you would like to look more on DAGs and try to use them. And once again, I completely agree that they are not the whole solution, absolutely. But it still stays a way of formalizing what you're thinking implicitly. So they help select confounders for adjustments. So we're at the analysis step. They reveal colliders, and so you should not adjust on them. They give you an insight of what you're talking about. Frankly, looking at the way the arrows go is quite interesting in thinking of what you're going to explore with statistical tools. Before statistical tools, you should really take time. It's not lost of time. It's a very important part at the end to say, well, I trust my results or not, because that's a problem in epidemiology. On my point of view, it gives you also some ideas on variables you should collect. So it is also part of the protocol phase. When you are thinking of putting in place a cohort or whatsoever, if you try to do the DAGs, and it will be imperfect, doesn't matter, but you see that some variables are necessary for protocol design, rather than putting everything in a model and letting the software decide, because that is what we do. If we do stepwise regression without thinking and accompanying the software, he will get you some associations, that's sure. But if you look at the ways of the arrow, the directions of the arrows, you will have some surprises, even if they get out some significant odds ratios. So I'm not against stepwise regression, it's not what I'm saying. But I'm saying that you shouldn't only put everything and look what the machine decides. You have to give some clinical sense in the choice and in the final results. So, yeah, that's just what I said. Give clinical sense to phase, protocol, till analysis. My examples here are taken, so don't try to copy the address. It's impossible. Well, all you do is Google and Shahar. Eyal Shahar has worked on those DAGs, and there's a free book on internet. He gives it, you know, you can dispose of it freely, and I found it really, really very, very clear. He takes all those examples, all the graphs I showed you are from his book, and he gives a lot of insights on confounding, causality, selection bias, and all that. Okay, and here's my mail, and I can send you my presentations if you ask them by mail. It's no problem. Yeah, that's what I wanted to say. So are there any questions? Yeah.
Well, I really found this presentation very, very interesting and a very, very clear way of showing collider, with the example on accident and streets and there. My question is, do the arrows always indicate a causal association, or are you considering also associations that are in your study base, but they are not causal?
Yeah, that's also a complicated one. Really, the problem of the selection of the variables is a great problem. So the problem is, why would it be an association without, without arguments for causality? I wouldn't say I wouldn't say you have to prove that the arrow is causal, but at least you should look after temporality, physiopathology. Why would you put an arrow on between sex and...
Maybe because you have a selection bias you want to adjust for or something.
But if the arrow is induced by a selection bias, it's a problem. It would rather have to be thought about before realizing the selection bias. Yeah. Yeah. It's still a problem if you don't have the idea of the mechanism, or because if you do your DAG looking at your univariate results, that's a problem, because some relationships in univariate analysis will be false because they are induced by confounders. So in epidemiology, if you take the first table, who is often disease, non-disease, and your variable in papers, and you take all those who are significant, well, don't forget it's univariate analysis, and so they don't take into account confounders. So they can be statistically significant, but you should have thought of why did you put it in the table in terms of mechanisms or temporality or other. It's really the difference between having a set of data and looking at everything. You never know, you could get something out. And thinking before, why am I putting those as potential confounders? Yeah.
Yes,
yeah.
Okay.
Luigi, yeah.
Just to come back on this point, I think that the reason for having DAG is exactly that you put the arrows where there are causal effects. So that if there is no arrow and you find an association, you know it's not causal. You will, of course, end up in the study base with associations. If you see, for instance, this one, smoking drive is associated surely with FEV1.
But, yeah, if here it's not association, I completely agree. If you don't have an idea how smoking drive would influence sex, which I can't imagine, or gender, well, don't put the arrow. So that means that it shouldn't be in your adjustment.
I mean, the drawing of a DAG is exactly to do this, to understand if you find an association, if it is causal or not. If you find an association, you have not put an arrow between them, that is, it's only confounding or selection bias that causes it.
My question was not related so much to variables associated with the outcome, but with other variables associated with the exposure. And sometimes the association, sometimes there is an association and it may not be causal, but it's still an association and can confound your estimation of effect.
Yeah.
So how?
Yeah, but you have to think about what does this variable represent, in fact, because you're speaking about the lighter. No.
Not really, because the lighter is not associated with the outcome, so it cannot confound.
The lighter is associated with reduction
not
of...
Causally.
Not causally. Not causally. No, absolutely. Yeah, Hobby. Yeah.
I'm a little confused still with the definition of a dangerous collider.
Yeah.
So my question is, from this picture, if the variables were something else and we just suppose that there would be on the age, physical activity, line, there would not be there would be no thinking of a causal association, but there would be an association.
Yeah.
And you would, in that case, you would include, say, sex, physical activity, and age in the same model. Would it still produce a false association between age and sex?
If you're thinking of the DAG as this, with no association between sex and physical activity, and you put physical activity in the model, it will collide, because in reality it's this. So it's not just designing your model and saying, well, if it's like this, I can adjust on physical activity. You really have to think of what are the associations between all the other variables and physical activity. So yes, I agree, we will miss some colliders, I agree. But on doing this, we also reveal colliders, because it's evident that there's activity between sex and physical activity, yes. And so this arrow is evident. But maybe we're missing this one. Yeah, I agree on that. But if you don't know it, you won't see it. Okay. But if you say, I have age, smoking, physical sex, I have these variables, let's just adjust on it, you're going to miss colliders. If you try to put them on a DAG, some of them will be revealed. Let's just put, is that your question or not at all?
Yes, some of it,
yeah.
yes.
Yes, some of it. Yeah, Kathleen, yeah.
If you adjust for both physical activity and sex, it's not a problem. The problem is if you only adjust for physical activity for the collider, right? Because if you adjust for sex as well, you close the path that you just opened.
Yeah, look. Yeah.
So if you also
by adjusting on physical activity, you open the path between the two causes. So this path is still open unless you adjust on sex also. So when you open paths with colliders, if you adjust on one of the variable of the new path, it resolves a bit the problem. Yeah. It resolves that problem because you close the new path. On adjusting on sex, you close that path. But the more you put variables in your model, the less power you will have. So you also have to keep in mind parsimonious choice. Yeah. Yeah, absolutely. Yes.
I don't know if you talk about this because I was late, but no, because I was late.
I'm sorry,
so
because the program
better.
isn't clear. It says it begins at 9 o'clock and the first presentation is at 8. So if I had known, I'd have come at 9.
So what about intermediate variables? I mean, that's another problem.
Yeah.
Probably
absolutely.
not in this DAG, but...
Yeah. Well, yeah, intermediate problem is per se a problem. So that's why I didn't too much talk about it. Yeah. And well, no, it was clearer in twins, and I gave an example at the beginning. No, excuse me. And it was something about twins and mortality. Yeah. So that was, and that was a problem because the arrows were not So should we adjust on intermediate variables? I don't know. Yeah, that's a good response. Because in fact it depends, and it's real. Rather no, I would say, rather no, okay? But as an epidemiologist, I say, but not always. So it's
difficult to give up adjusting for gestational age.
Yeah. Gestational age is really a hell of a problem. But let's say that for the course we would say, don't adjust on intermediate variables. Yeah. And because we're not, well, no, we're not going to go in there because we're already late. Okay? So this was the part on DAGs and confounding, and just don't forget to try to put your ideas on a paper, even if your DAG is not. In the book of Shahar, you also, he uses DAGs for selection bias, information bias. He develops the use of DAGs if you want to go further, unless you're already convinced that it doesn't, it's useful. Yeah.
Not useful, but it's just a tip. Do you know the DAGS website? There's a website where you can use to draw your DAGs, and it's just useful if you're new to this. It's called DAGITY, DAGGITY.net. DAGITY, yeah. You can go and you can put in your exposure and your outcome and all your other variables, and you can put the arrows in the directions you want. What? DAGGITY.net. Yeah. Two G's.
Okay, thanks. DAGICY. DAGICY. Okay, thank you very much.